So good afternoon, ladies and gentlemen, and my name is Fajadet, and I have really really happy to share this session on the robotics, and I have no conflict of interest to report. And the session objective today are to learn about the robotic PCI, and we'll look at all the step-by-step from real-life experience. The second objective is to understand what are the benefits of the robotic in interventional cardiology. And finally, to look and dream what will be the future in the next 10 years. And you will see that with the arrival on the artificial intelligence combined with the robotic, I believe that our work of interventional cardiology will be totally different of what we are doing today. So this is a slide summarizes the agenda of the session. Dr. Bedogni will start by showing a really interesting robotic case. Then we'll be followed by Dr. Gilles from Warsaw, and will give us some data and cases from his experience. Then we talk about the clinical result with Stéphane Verheye, and followed by Dr. Gaston, who will talk about how should I top robotics in daily practice. And finally, we try to show you what we could expect from this technology combined with artificial intelligence. So we can start by the first presentation with Dr. Francesco Bedogni. Francesco? Oops. Sorry. It's here.
Thank you. So, good afternoon. So we'll present a case, not a so spectacular case, but a typical case that we perform in our cath lab with a robot. This is my conflict of interest. This is the patient clinical presentation in a 71 years old woman with hypertensive, all the risk factor for coronary disease, is admitted in our hospital for acute coronary syndrome with the diagnosis of non-STEMI and rise of troponin. This is the angio done immediately. There is a mild lesion of the IRCCS, and the left system has a moderate lesion of ostial LAD, a tight lesion of the middle LAD, and a bifurcation lesion at the mid circumflex. So we decide immediately to treat with robotic procedure the left anterior descending artery, no problem. We plan the procedure for the treatment of the bifurcation lesion of the circumflex next day, and we recorded this case. So this is recorded. So the procedure is performed by two very young operators, one young operator and one fellow. The fellow is inside. The only person that is inside the cath lab, protected by a screen, and all the other people outside. She's charging in the robot machine the J connector, and this is the main path for a working path for wire and balloon, and there is a standby path. We started with a normal right atrial access. We put immediately 2 wire because we plan to use 2 wire. And to stabilize the catheter, but we didn't touch anyway during all the procedure the guiding catheter. Then we plan to perform a drug-eluting balloon PCI with FFR monitoring. So we place in the main vessel, in the main circumflex, an FFR wire from the beginning. You know, this is not the same torqueabilities of the common wire. Anyway, you will see on the left with the right hand on the right, Mattia Squillacci, is the operator, will push the wire slowly in advance. You can push quickly the wire inside the catheter, but outside the catheter you push the wire slowly. We have some tortuosity there, so Mattia will pull back and advance, and he can turn the wire with the joystick, so we can do drilling, you know, it's advancing and turning. So there's a very nice track of the wire. So we have the FFR wire in place. Alice, it's a fellow inside the cath lab. In fact, he changed the path, so we put the previous wire, the FFR wire, in the side path, and I put in the working part the second wire to insert the wire in the marginal branch. So it's ready. That's okay, you know, there's a screen, and Mattia is outside, and he moved the second wire now. This is quite easy to go this a Sion blue wire. It's easy to insert in to protect the secondary vessel. Same problem, tortuosity. It can move very easily. He advance. Stop, and we pull back because when it's stuck, and then go drilling, moving the joystick and advancing. Done. So now we start with the balloon, pre-dilatation with the balloon. I told you that we plan to perform a drug-eluting balloon PCI, but we decide to pre-dilate the lesion with the balloon, and with the left hand, it advances the balloon with the precise movement. We just to avoid to skip away, and we pre-dilated the 220 semi-compliant balloon, inflated to 16 atmosphere. This is the result after the balloon dilatation. Seems good. So he retracted the balloon. The wire is still in place, so we don't need to do anything. He retract the balloon. He's discussing with me. I'm absolutely relaxed, and now we are eating outside. So it's absolutely relaxing procedure. And then we put the drug-eluting balloon. You know, there's only one operator in a cath lab, Alice, behind the screen. So we are without any kind of, we inflated the drug-eluting balloon. So the only thing that we need to be inside is to inflate the balloon and during the procedure, because we have not so prolonged to go outside with the inflator. This is the result after. This is the inflation of a 2.5 26 drug-eluting balloon. If you remember, we have the FFR inside, so we can measure the result. The FFR is absolutely good. The result is 97. But if you see the angel, there is a dissection that we discuss. We can leave, or we put a stent. We decide at the end to fix the lesion. It's an acute patient performed the day before, so we put a stent in the same working path. You know, we implant the stent. We have a very precise position on the stent. We put a 2.528 drug-eluting stent. This is the inflation done by Alice. Now we have the jailed wire in the marginal branch. Okay, so we decided to to change the wire and measure if you have some split of plaque, if you have a reduction of flow in the secondary branch, and voila, very easy to insert through the stent struts the FFR. Very controlled movement of the FFR, leaving the other wire in place, jailed. Perfect. We are on top. We remove the wire jailed, and we reinsert the other wire in the main vessel. Now we can measure after the placement of the second wire in the main vessel. We have the FFR now and we measure the FFR in the side branch. It's a 1, so perfect result. We don't need to do anything, and then we go again just to be sure through the stent to measure the final FFR. Beyond the stent, 1 is absolutely normal, so it's a perfect result. So at that point we have angiographic images and functional images in both the vessel. We finish measuring the FFR in the proximal ostial LAD. There's absolutely 0.98, so normal. So we finish at that point the procedure. This is the final result you can see, and the functional evaluation of both the branches of the circ and the LAD. So the take-home of the case was there was an easy robotic treatment of bifurcation lesion in tortuous vessel with subsequent manipulation of both wires. We had to change in a standby path to the working path the wire. The procedure was performed by 2 young operators without additional procedure time outside. The case is performed by after a short learner curve, and we have the possibility then in the next presentation we will see that you can use different tools. If you have seen the FFR, you can use IVUS, guided extension, shock wave. Everything is possible to be performed with a 0.014 wire, and obviously the main issue is that there is a very low X-ray exposure for all the team. Thank you for your attention.
Dr. Bedogni, you want to say just a brief 4 or 5 minutes so we have questions? So first of all, questions in the room you would like to pose? If not, then I can start. Practically speaking, what kind of lesions you are looking for at the moment when you offer a robotic PCI to your patient?
Well, sometimes, the lesions are surprising. In the same day, we recorded another case with a little bit calcified lesion over RCA, and it was a very long case because it's calcified. It was impossible to go through with the balloon. We couldn't relate. We had to use a wire extension. We use a shock wave. So sometimes, we plan to perform at this moment quite simple lesion, but I think this is not so simple. The bifurcation lesion of the circ. But sometimes you have some surprise, and so you continue robotic. Obviously, we can do an hybrid procedure. So in some situation, you can remove the robot, continues by hand, and we'll finish with a robotic procedure. So this is a good possibility because we can start with the robotic procedure, but we can stop and go through the normal procedure,
So I don't stop to motivate you, ask questions. We have stand-up microphones, so please use them if you want. In the meantime, some of our colleagues like to know whether you can use both radial as well as femoral access with the robot.
This is a question for me.
Yes,
well,
all questions are for you. At least at the moment.
No, it's okay. No, we try to do the same procedure that we perform without robots. So I think that an advantage is to use a radial access, 6 French catheter. I know what we need probably sometime more support. So in some cases, it's more useful to use the femoral 8 French. Michael Ode last year showed very fantastic complex cases with 8 French. But I think that you can achieve a good support with 6 French from radial access, and we have catheter for to do that. I will use a normal radial access. You know, sometimes in this case, I know that I have to use two wires, so I use the standby wire to stabilize the system, and might be helpful. You know.
Another practical question. I think there are two ways to manage or manipulate with the wire. The one is you bend the wire, the other is to kink the wire. So these are two different worlds of how to manage it. So you do it in the same way with the robot, like you do it manually, or you experience some kind of change that the robot is taking it a little bit different than when you do it manually. What is your experience?
I can tell you about my experience from the beginning. As in 1985 years, I start to curve the wire, and I continue with the robot to curve the wire, not to kink the wire. I prefer. I think it's less aggressive.
Honestly speaking, I have the same history, but now a bit different experience, because I kink the wire now with the robot, and I find it easier to steer rather than to be bended. But this is an individual thing. Everybody needs to check that for his own and personal experience, how to manipulate the wire with the robot down there. So, no other question? I don't see that. John, anything to add from your side?
Just a question. We saw that the circumflex, and particularly the OM branch, was a really tortuous branch. In this particular case, do you use the same wire as you use for a manual PCI, or do you preferably use an hydrophilic wire?
No, we use no. We don't use the hydrophilic wire is less dangerous in robotic PCI, because you control. We don't lose. It's fixed. So this is an advantage to use Teflon coated wire, because we don't risk to perforate moving with wrong movement of the wire. In this case, this particular case, we use FFR wire. So this I find that they have a very, very good feeling to move it with pushing, drilling. Mattia is a great specialist on it.
Okay, you can continue.
Okay, thank you, Francesco. And now it's time to move to the second presentation given by Robert Gill. Will show us his experience from several cases that he has performed in his cath lab.
Jean, thank you very much for inviting me. I would like to share my experience with a couple of cases, exactly 4. The first 3 will be, I would say, easygoing. The last one, I would like to bring your attention to all the let's say, moments of the procedure, because that was, in a certain moment, complicated. But we found a way out. How can I... Okay, it's...
Double click.
Okay.
Presentation.
Sorry. I have no conflict of interest in this particular presentation. So this is a bifurcation lesion, which was predicted to be treated as a provisional, according to the provisional T-stenting access. You see the history of the patient, nothing special. We try to perform functional assessment during the diagnostic phase, so therefore you see the results showing of the functional assessment, this circumflex artery, that was a significant lesion. So we decided to go with a robotic approach. Here you can appreciate that despite this very irregular let's say lumen of this vessel, it was not difficult to wire both branches. Here you can appreciate the results of IVUS assessment. We try, and we succeed in more than 95% of cases to, let's say, IVUS guidance. It led us to adapt proper additional tools to prepare the lesion and to improve or optimize the final result. Then, because of the IVUS findings, we decided to predilate with a cutting balloon. Here you can appreciate two positions where it was performed. That was Wolverine 3 by 6 millimeters without any problem tracking and preparation of the lesion. Here you can appreciate this effect of predilations, and here we started to deliver the stent CryoEvo 3 by 16 and implanted across the, let's say, from circumflex to marginal branch across the distal circumflex artery, redilation with 3.5 NC balloons, and final result. So I can easily say that an assessment with IVUS showed us that the result was at least very good. So for this provisional T-stenting bifurcation lesions, robotic PCI or PCI with robotic assistance is really very nice. You can eat, you can drink, you can discuss, of course, without exaggerations, because you have to be concentrated. However, it's a big fun. The second case is chosen by me because we use for in-stent restenosis laser wire. This is also an option, especially this is the best indication for laser. This restenosis was the third one, so that was a really neoatherosclerosis. And here you can appreciate that the lesion was not very long, however tight. We were able to perform, after small predilation with 1.75, the passage of IVUS was possible. You can appreciate here these tissue characteristics in this in-stent restenosis. Based on that, we started with laser atherectomy. We use 40 by 40 the setting for laser. If I remember well, 4 passes, and then balloon predilatation, and we finished the case. And we finished the case with drug coating balloon, paclitaxel balloon. Here you can, no, that was a sirolimus, magic touch 3 by 25, and here you can appreciate the final result. We were very happy. We checked it with IVUS with very good result. However, we discovered the problem with first marginal branch, and using the wire from marginal branch, I was able to, let's say, to reopen with 1.75 balloon also this side branch. So it was easy. The usage of a second, the same wire was possible. Here you can appreciate a real result with a good flow also in first marginal branch. The case number 3, that was a case in a patient after cabbage. That was saphenous venous graft, bypass graft to right coronary artery, closed, very almost in the anastomosis position. It was very easy to catch this lesion, to deliver the wire distally without, believe me, without any problem. I usually use BMW or Cyan Blue, these or regular Cyan. These 3 wires are usually used for this situation. Here you can also see the positioning of the balloon. here predilatation 2.5 by 15. You see that the result is not fantastic, so therefore we decided to go for stenting 3.0 by 16 with 16 atmospheres, and you will see the final result confirmed with the IVUS assessment at the end. Everything with the usage of R1 robot from Robocath company. And number 4, that was a case that the patient had, this is acute coronary syndrome with ST elevation, however with a late hospitalization, at least one day, and after the admission, the PCI only with balloon was performed for distal LAD. The rest was left for eligible procedure. However, the patient started to complain, and 2 days later we decided to go, and decision was to use robotic support. Here you can appreciate the tortuosity of circumflex artery, also LAD, very developed, very advanced atherosclerosis. You can please look at the proximal left main, which is heavily diseased in the proximal part. I use 6 French catheter. I decided to go with 2 wires. Just a couple of movies showing that the wiring was not very difficult. You know, in terms of manipulation, advancing the wire with the robot, you know, I feel this textile. It's not that it's something artificial. I really, this is not the same as live with the hands, but still you see and you feel this wire, and never exceed with the loops at the end of wire. So we decided, we succeeded also with this very tortuous LAD. I tried to show you that it's really possible. So we succeeded, and then we started to proceed with the procedure. We started with, as usually, with IVUS from distal circumflex artery, also assessing the left main. We sized everything. We knew the vessel, the real vessel dimensions. So therefore, I decided to go with the 3.0, not NC, but regular balloon predilation, and then subsequently I decided to go with the Or0 mission 3.5 by 26 to the distal position. And I would like to say you that I found as a very helpful this kind of maneuver, that you still try to advance the wire with this continuous speed. However, you can accelerate the wire from time to time, periodically, and it's kind of pick and poke technique, and so therefore I was able to reach these calcified and fibrotic lesions distally without big problems. So after first stent implantation, I decided to use another one. From the IVUS assessment, the proximal part of circumflex artery, the orifice of circumflex artery was relatively healthy, so I tried to keep it without stent implantation. So the next step of the procedure was to stent with 5.0 by 12 onyx true star treatment of a left main. And here you can appreciate the positioning, and I hope you agree with me that this position looked very promising. That was in the right position. And here appreciate the situation of after left main standing. Here you see the dancing stand in the left main. We still kept the wire in the circumflex artery, and you see that the stent is undersized. This is one. Is prolapsed very much to aorta, but we had still the wire in the circumflex artery, and then there was only one decision: the next stent, a little bit smaller in size because of the distal reference. So I decided to go to the beginning of second stent in circumflex artery, implantation and redilatation with the port technique for proximal part. You can appreciate it here. And here, this is the final result. Look at the next. You see the prolapse, the protrusion of the stent into the aorta, and I was able to perform also the IVUS assessment, and then you can appreciate that the distal is well opposed, everything is fine till the end of left main, but you see here the protrusion of the stent. That was a kind of a complication, and I'm very interesting what is your explanation, because my explanation is that there were 2 or even 3 small mistakes. The one mistake was that I undersized the stent, because this 5 was only for distal part of the stent. The proximal was around 7. And in the moment when the stent was dislocated, why? Probably because of the balloon. I pulled back the balloon too early. There was still some wings, because that was 5.0. After, if I remember well, 16 atmospheres, and probably I moved this stent proximally, and the next steps were difficult to redilate maximally, because first of all I decided to use 6 French, not bigger, and the second, with this redilation with bigger balloon, I could really lose this stent from left main. Anyway, this is a setting in my lab. It's like we work with R1 system. We really enjoy, and our feeling right now is that we are able to perform more than 60, even 70% of cases from the technical, anatomical problems. Still, this is the ideal system where you don't need a second wire and second device. So if you need it, it's possible to do that, but you have changed the path. You have to work on two vessels. Thank you very much for your attention.
Robert, great cases. A few questions. What do you think about the learning curve? How many cases you need to perform until you get a good feeling in your stomach that you can do things like you have shown to us?
Okay, first statement, I have never played with game boxes.
But you are old enough for that.
But after 3 cases, I started to be very familiar. I started to love it after 5 cases. So my feeling is, if you are experienced traditional interventionalist, you need 5 cases, let's say, to be good. However, might be that somebody very experience with this manual tactile will not feel very safely familiar. For me, that was not a problem. After 5 cases, I would say I can do everything.
Okay, not everybody is you, but you see, it's a reasonable single-digit number. Another question: you showed us nice IVUS images, all done with the 20 megahertz old Volcano system. So some colleagues might ask you, what's about the new high-definition IVUS? What's about OCT? Can we use these technologies also with the robot?
In terms of this not electronic probes, it's feasible. This is not a problem. The problem is with OCT. We haven't tried it. Theoretically, it's possible. However, probably I had, so therefore I didn't try it. That there is a problem with the proper adjustment of the size of the catheter, catheter and the rolls in a arm, working arm.
Do you use the same guiding catheter configuration that you would have used if you would use your manual approach, or do you have slightly different?
No, this is the same. This is the same approach as for manual.
Okay, and if you need it, can the robot advance a guide extension?
Yes, it's feasible. It can be done. You can fix the additional, let's say, catheter within the guide, and you can use it through the procedure. It's feasible.
And one final word on the precision. I mean, we have nicely here you in front of us, sitting in front of your monitors. I think the distance between your eyes and the monitors is around a meter or so. When you're with your colleagues in the cath lab, usually it is a longer distance. You have, or do you experience a difference when you sit there and do the manipulation versus standing at the table, looking at even a large monitor in front of you, but it's a slightly fewer away?
Michael, I'm in a very bad situation right now, because until the last case presented right now, I was sure that this is much more precise. Let's say I am much more precise. I feel very confident in that. But after this case, I'm not so sure. So I made some mistakes. Maybe I was too sure. That was too easy for me. But the problem is that we can to be precise, but you have to take into consideration systolic diastolic movement of the heart. You have to take into consideration the sudden exhalation or inhalation of by let's say given by the patient. So it's also very important to know the plaque characteristics and prepare to prepare the lesion properly. But theoretically and in the majority of cases, you feel that you are very, very precise, much more than manually, because first of all, the monitor, the screen is very close to you, and the second, you can really move the balloon or the stent by 0.5 millimeter. But you have to take into consideration systolic diastolic movements.
And I think we need to emphasize that at the moment, in particular with respect to your last case, the system is not capable to manipulate the guide. So the guide is still in the position where it is, and the only thing you can do is try, if possible, to manipulate the wire. If you push the wire and hope that you can disengage the guide a little bit. But we know that is creating significant instability. So next gen will for sure help us to manipulate the guide. Robert, I think we covered all your discussion time, or is there somebody in the room?
Before moving to the next talk, any question from the floor? Do not hesitate, and we have time. You can take a microphone and ask your question. No question?
No question.
Okay, everything is clear? Okay, we can move to the, thank you, Robert. We can move to the next talk. We'll talk about the late clinical result, and Stéphane Verheye will show us some data.
Thank you, Jean, and I'd like to thank the Robocath for having us here available and for giving the possibility to give this talk. So I'm going to talk about the latest clinical results. So basically my talk is going to be split in two talks. One is going to be sharing with you the clinical results, what is out there today, and also a sharing of a survey that was done by two interventional cardiologists, and to give you an idea as to how everybody thinks towards the use of robotics in current era. What I'm going to be doing is about this clinical data is, first of all, the R1 robotic system is available in EMA and China. And so therefore the studies that have been done is the R1 study so far published, and that's one European study. There's a Chinese study that's not published, and there is a South African registry which is also not published yet. So altogether there is about 251 patients enrolled. It's prospective, multi-center, single-arm report of clinical study. And the indication of the inclusion were patients with de novo coronary artery stenosis that were candidates for PCI and deemed appropriate for PCI with the R1 system. The follow-up is 1 month, and the primary endpoint is primary safety outcome, absence of intra-procedural complications defined as clinical success, as well as the primary efficacy outcome defined as technical success, a successful advancement and retraction of the PCI devices, and a successful treatment of the target lesion without total conversion to manual procedure. And you see that the people involved are listed on the slide from Europe, China, and South Africa. So when we look at the population and the angiographic characteristics, it's interesting to see that the mean age is around early 60s. The predominant population was consistent of male, 80% is about male. And then the rest is actually what we classically see in the PCI population. What is interesting is that also a patient with a STEMI has been enrolled into this analysis. In terms of variables, and the question was already raised in the first talk, so the radial axis was 91.3% in all cases. In terms of complexity, I think it's important to mention that about 40% of the lesions treated were complex lesions. And the sheet size was always 6 French, and pre-DIL was performed in 80 and DS were done in 100%. Post-dilatation was done in almost 70% of the lesions. What about the results? The procedural characteristics in terms of primary endpoints, you see the clinical success was 100% at hospital discharge and well at 1 month. In terms of technical success, the success rate was extremely high, close to 99%, and there's 2 out of 3 of the manual conversions were not related to the robot, so basically just 1. And I think when you look at the data on the right side, that's what it all comes down to, is the procedure time is altogether is 57 minutes with a robotic time of about 22 minutes. The use of contrast media in robotic use is 91 ml. And when you actually compare that to the manual data or previous robotic systems, that is actually very good data. Now, I think which is important for all of us doing interventions, is the radiation exposure. And I think that one of the reasons why this is all being developed is just because of the reduction in radiation exposure. And as you can appreciate, you actually have a more than 90% reduction in radiation exposure for the operator. So I think taking this into account, we can obviously say that robotic PCI is undoubtedly safe and effective, and as we also have seen from the nice case examples presented by the previous two speakers. So, but I think what is interesting now is what it was, so this is an important analysis also for Robocath, is how is this robotic PCI perceived by the community? And I think, so this is the second part of the talk is, so what about the survey? You know, asking the impression of interventional cardiologists, whether they are heavily involved or just have heard of robotic PCI, what do they think of the use of robotic PCI? And so what they say, the number one is radio protection for 47% of the responders. They mentioned that operating from the control room is being perceived as the most effective radio protection, as you also have seen from the data now. It is still high, the concern for radiation. And as you know, not only radiation, but also we all suffer from musculoskeletal disorders and have 1 out of 10 have health-related period of absence due to these problems mentioned. The number two is the precision, as we also have heard in the previous talks, and that's for 43% of the responders. Indeed, precise and safe wiring, accurate stent positioning, and also the locking of permanent devices. So about 66% responders consider robotics bring precision to the procedure. And then number three is the comfort. I was a little bit disappointed that we didn't see the glass of red wine in the previous. We saw a sandwich, but I was hoping to see a glass of red wine. Anyway, it's just illustrating how comfortable it is to be doing a procedure from your seat away, actually, from the patient, even though, not to forget, somebody has to be with the patient for safety. So all in all, 87% believe that robotics would improve the quality of the intervention and or consistency of the results. And this survey was also performed back in 2019, where we mentioned 61%. So definitely a significant increase. So it's all good to mention, what are the advantages, but I think it's important to give away also some actual limitations. And so what are the actual limitations to global adoption? And again, this is data from the survey, and it's interesting to see that the price is an important one, the clinical evidence on the routine use and the clinical application, and the features to be added for mass adoption, as you can see, is the force feedback, the tactile feeling that one can get. Obviously also the possibility to have 2 wired tracks and 2 sidebed tracks, force device adjustment, and the compatibility with diagnostic devices. And of course, obviously a list of other ones, like Michael already pointed out, is the guiding catheter robotization. So 90% would consider using on daily practice of a robotic generation able to manipulate a guiding catheter, 2 guide wires, 2 stent balloons, and a microcatheter. And 93% if the robot demonstrates ability to treat all kinds of lesions, including CTO. So I think definitely we have made a significant progress. There is still room for improvement, but I think we are, people like Robocath, they're working hard on that. And it's very impressive to see that we have seen a significant amount of progress in the last couple of years. So with that, I'd like to conclude. Thank you for your attention.
Stefan, thank you very much. Very interesting information. And the first question from the floor.
Yeah, hi, how are you? I'm Ronnie Chantou from Cleveland Clinic in Abu Dhabi. I have a question. One of the number one responses is that it reduces radiation, obviously MSK. This is quite helpful. I just wonder, should the comparator be what we're doing today, or should the comparator be against these different shield devices that are available, where you can actually do the case without needing to wear your lead shield or have to worry about radiation? Because that seems to be the true comparator going forward. As of today, I know most of us, probably a lot of us, don't have access to that. But if we're talking future, that's one question. Two, a totally separate question, how easy is it to, if there's a complication and you need to switch and you need to let up and move in the room, how easy is it for you to convert and just take control of the device and the equipment and switch to your traditional approach?
Yeah, thank you. Very good questions indeed. In terms of the radiation safety or reduction in the radiation, I think with the current technology that is out there, I think this survey was made when the comparator were what we are doing today without the use of the current devices. So I think it would be wise to repeat that survey and ask what they think, what people think today of using it. Like, you know, what is the Rampart and all the other kind of devices that are being introduced nowadays. So I think it's a very fair point. But still, as you could see, you can, you know, be remote from the patient, be relaxed, doing the case. And I think this is different from the shielding that is being introduced in many other cases today. To your second point is what is the conversion? The conversion is actually very easy. It's you can just take it out of the box of the toolbox and just do it by yourself. Then, luckily, the conversion rate, as you have seen, is very low. So we're not in a situation that we have tons of experience in doing that, but it's definitely very easy to do so.
Stefan, I think you have equipped one of your cath labs with the robot, making it the robotic lab. Now, if you have a patient there being diagnosed and it has a suitable lesion, are you doing an ad hoc robotic PCI or you make it always in an elective staged way?
So in our lab, the way it works is that we do most of our cases electively. So that's one thing. But if there is a case where you have unstable angina, nothing prevents us from doing an ad hoc PCI. It's not routine, but it can happen. And we are part also of the ongoing registry. So we try to schedule the PCI electively. So, but both possibilities exist.
Another question that is quite frequently asked is, how do you inform your patient when you move into a robotic PCI? And do you need to have a dedicated informed consent for that kind of procedure from your patient?
It's interesting because so the answer is no. Because but still I want to add because people know that you're doing robotic, and some of them is the robot going to do that, doctor? And so and then you actually don't have to ask the question anymore because they're asking it themselves. So, but you don't need an informed consent, except when you do a registry or a trial, obviously.
Yeah, I think it's a CE marked device, so I mean it's not something experimental. Nevertheless, it's reaching an amount of information that the patient should require. So at least what we are doing is we put that on our regular PCI consent form that we're going to attempt it via a robotic approach. Yeah. Stefan, thank you so much. Pleasure. Covered all the questions. And Jean, then we continue.
Yeah, and now we invite Dr. Richard Gaston, and we will talk about why is adopting robotic PCI in daily practice.
So thank you so much for your kind invitation. I am a urologist, and I had the opportunity 25 years ago to develop a radical prostatectomy by LAP. We were the first in the world to do that, and it was, for me, easy to move from LAP to Robo, and we began robotic surgery at the beginning of the 2000, and we had 23 years of experience of robot in surgery, and I can give you some message about the evolution of robotic surgery in urology especially. So I have no conflict. So we begin by a short history of the robo in urology and general surgery. We begin by a very simple robo with 3 arms in 1999, and we move very quickly to a second generation with 4 arms and HD vision. So it was clear that the operating field was much better, and it was easier after 5 or 10 procedures to see that we have a much better operating field than in conventional laparoscopy, and the mobility of the instrument was much better than the human hand. So the third generation, we had some more device like fluorescence and the evolution of the HD vision. So the last generation of SI was really the beginning of the development of robotic surgery, especially in urology. And it was in 2009, we have a robot much simpler, more compact. It was easier to introduce the robot in operating room without any problem. And we were doing more and more procedure. Really, at around 2009, 2010, we moved completely from open to robo for every procedure, even cystectomy and neobladder. In our institution, we stopped open way at that time, moving completely to robotic procedure. So the last evolution is the XI. What is interesting in the system XI, there is no conflict between the 4 arms. So it was easy, and it's easy today, to make a partial nephrectomy. And I can say that the victory, one of the victory of the robot is to come from nephrectomy to partial nephrectomy. And now today, when we have a tumor of the kidney, with the help of the robot, we are able to remove just the tumor in 95% of the case. The last generation is the new system of Da Vinci. We have today the feedback. It's a new generation, but really it was not necessary to feel anything because the quality of the vision was absolutely so nice that the feedback was not necessary. So before beginning robotics, we have a lot of questions, like everybody. So what was really the benefit of the patient? Is it safe? It's more precise than the open way. It was not longer time than manually. What was the real cost? What was the learning curve? What was the additional physician needs in the operating room? And it was really possible to do completely the procedure robotically. And today, after 20 years of experience, we have the response to this question, of course. And at the end, the physician can be replaced? No. Today, the physician is much better than before. So what we can say objectively, when we remove a prostate, for example, we have less blood lost, less pain, less recovery time. So it's safe. So I think today we have less complications than before. The stability, 3D vision, of course. And about the time of the procedure, this morning, I removed a prostate in 22 minutes. 10 years ago, in other centers by open way, they need 1 hour and a half, 2 hours. So today we can say that the time is reduced by using robo. What is the cost? Of course, the cost is higher, but the patient you treat today will give the hospital tomorrow morning. So the hospital stays much shorter with the robo. The learning curve, I have the experience to see young surgeons able to do a very difficult procedure much easily. I think the education of surgery today is easier than before when we were opening the patients. What we need, one surgeon, one assistant, is not necessary to have. We have just 4 instruments. For the assistant, we have a suction device and grasper and some staples, nothing else. So the number of instruments had reduced alone. And of course, we perform the procedure completely robotically. It's not necessary to use hybrid procedure. When we have some adhesions before putting the arm of the robot, we remove the adhesions laparoscopically. So I think it's really a progress. There is no discussion. Today, the open way in our specialty is died, and the present and the future is robotically, of course. And I can say that the physician today is much better than before because we have a much better knowledge of the microanatomy of the prostate, the kidney, and the bladder, of course. So what we can say, robotic gave a lot of benefit to the surgeon. We have 4 arms, instrument with higher direction to work, and of course it's less invasive for the patient, less pain, less bloodless, and of course the physician, the comfort for the physician is higher. We can perform with a single console and turbo, we can perform 7 or 8 radical prostatectomy per day. So the cost, of course, it's probably a problem, but if we look at the short hospital stay, it will be reduced. Thank you so much for your attention.
Dr. Gaston, thank you very much, because you opened our eyes how surgery managed it to get the robots integrated into their daily life. Can you tell us, I mean, you have these experience in advance of us. What was the major reason why robotics became so attractive to surgeons? Nowadays, I mean, you showed us the surgeon is not working without any longer.
No. I think what was for it, I think it's evident because you have a fantastic vision. It's fantastic vision, and the mobility of the instrument. We have instrument with 8 axes of mobility. And for example, when you use a scissor, you are able to cut from above to you. And I think it's so clear. So the operating field is so, the gas is helping you. The gas is the first assistant of the robotic surgeon in our specialty, and the operating field is always very clean. And open way will disappear. We never had scientifically the proof that the open way was worse than robo, but today open way is completely died. It's evident. It's a level of evidence number 1.
Okay. The question is, there is one major contributor in the field of robotic surgery. You showed it us.
Yeah.
They have quite a history, and they have a multi-billion-dollar impact into the evolution of that technology. Question nowadays is, you think we can replicate something in cardiology?
I think the next step is probably the telesurgery. Is the next step. We can add virtual pictures in our screen. For example, for kidney tumors, when you are dissecting the kidney, if you don't see perfectly the tumor, you can introduce in the robot the virtual picture to see where is the tumor, where are the artery, the vein, the urinary tract, And so it's easier and easier and easier, and the learning curve. I think it's one of the most important message. The learning curve is much, much, much shorter.
So I think you pushed us to continue in this way.
Absolutely.
I'm very grateful for this because you still, in our community, there are a lot of people who are saying, well, I can do best with my hands and my brain, and no computer will beat me at any time.
Yeah, you know, we had to fight. I begin lab in 1991, 92. We have 15 years of fighting against open surgeon, but today they don't speak and they will disappear.
Okay, thank you very much.
Thank you.
Thank you. And now it's my great pleasure to ask Jean to give the last lecture of that session with his personal perspective. Where are we with robotics in PCI in 10 years from now? Jean.
So I have no conflict of interest. So what I would tell you is not experience. We are talking about the next 10 years. So we have experience from the surgeon, and they explain how it was difficult with surgical environment many years ago, and now the policy are totally changed. So the question is, do we see the same evolution in PCI that the surgeon saw in the last 10 or 15 years? So what we can see today is that robotic PCI is feasible. You saw that several cases, very nice cases. It's safe, and there is absolutely no increased risk for the patient. We know that. There is a large experience with single vessel and single lesion angioplasty, but in the same time we can say that we could treat patient with multi-vessel disease or multiple lesions. When you look at the complexity of the lesion treated by robotic, complex lesion, in other words, long lesion, bifurcation lesion, and osteal lesion can be safely treated. What I will say, certainly, the most interest of robotic is for osteal lesion. Could be osteal RCA, osteal left main, or osteal side branch within a bifurcation. Comparison to manual PCI, at present time, it could be a little bit longer than a manual procedure, not because it's the way the time to treat the patient, but it's the way to prepare the robotic around the patient before starting the procedure. Second, in some complex lesion, you could have a higher contrast volume and a longer fluoroscopy time. So what you could say is this is definitely reduced by the experience. Sorry. So what we have learned is that the robotic benefits are the precision in the wire navigation. And we saw one of the first cases with this, very tortuous circumflex marginal artery. You saw really the navigation of the wire with extremely precision. The stent positioning, again, is like the osteal lesion. The stent positioning is really millimeter by millimeter. And you have time to advance or remove the stent. Full radio protection, and it's true that this is an important advantage for the operator. In other words, you could work sitting on the chair outside of the guiding without any X-ray exposure. And it's true that there will be, certainly in the future, a reduction of orthopedic injuries. Of course, we need training for all the new procedure. Importance of the communication between operator, between the cath lab and the control room. And we need a technical improvement for smoother use in a complex lesion. We can today use parallel wire. We saw during the cases balloon stent for bifurcation, the treatment of bifurcation lesion. Over-the-wire device compatibility we have discussed with some devices. And again, the full cath lab integration. But this is it's facilitated by the number of cases that you are doing. So what we could say, sorry for the, when I click it, cannot advance. So these are the current situation in 2024. What could be the future? Certainly the future will be combined in the next 10 years with the arrival of artificial intelligence in interventional cardiology. And I'm fully convinced by the fact to get this artificial intelligence in our environment in the cath lab, we change totally our way of working. We change our way of diagnostic, our way of decision of treatment for the patient, integrating all the clinical characteristic of the patient and geographic characteristic of the patient, biology characteristic of the patient, etc. And artificial intelligence will give you very quickly and fast the best way to treat the patient. So artificial intelligence is an umbrella term for a set of multiple algorithms that imitate intelligent human behavior, but are certainly will be more efficient than our brain. The application of artificial intelligence in interventional cardiology, in fact, will be divided in two main branches. First, the virtual, and I talked to you about the machine learning, deep learning, and the connective computing to control health management system. And the second will be the physical branch represented by the robotic procedure. Sorry again. So the future will be based on the potential application of artificial intelligence in interventional cardiology concerning image, video analysis, clinical decision support, novel approaches to clinical database analysis, augmented reality platform, voice power virtual assistant, and robotic assistant with a procedure. And artificial intelligence in interventional cardiology, today it's an early stage, but there will be a rapid evolution, and I am pretty sure that this will transform our way of working. So what could be the future catheterization laboratory with artificial intelligence-enabled technology? This could be a schema of the cath lab in the future, and you could see that first, the operator will be sitting in front of a large screen. Second, there will be the clinical decision support system. According to this, will be collect all electronic data, medical support, etc. What I tell you, and at the end, the machine will give you the best indication of treatment, the best way to treat it. Then there will be connected with a semi-autonomous vascular robotic system we will see improvement of the technique year after year. And what will be interesting, that we will work in front of an augmented reality system, which will be totally different of what we have in front of our eyes today. So the integration of the cath lab over the coming years, we go to the fourth generation that we saw during the previous presentation. So for the Da Vinci, we are there. They are moving to the fifth and the sixth generation. For the robotic PCI, we are today at the second equivalent of the second generation. So we expect that in the next coming years, there will be better connection between the cath lab and the operating theater concerning imaging and the table, and for the fourth generation, with the total integration of the environment based on artificial intelligence. So this is coming from a questionnaire and answer by the cardiologist, and you could see that close 70% consider that robotics open new possibilities in the term of treatment approach and device selection. 87% consider integration with the imaging system, which will be crucial. More than 80% would adopt robotic if it was able to treat any kind of lesion. Question could be the CTO. Of course, it depends on the anatomy and the indication. And close 80% of the people consider that using robotic will be a potential solution. So today we are here. In other words, we are performing procedure with a lesion characteristic assessment based on invasive or non-invasive tools, invasive FFR, QFR, IVUS, or CT, and the lesion wiring. Today, the robotic navigation can do it. Concerning the lesion dilatation or the lesion stenting, the robotic today can do it, and again with extremely precision, millimeter by millimeter, particularly for osteolation. Concerning the correct positioning and deploying today, we are based on these invasive tools, and today the procedure location. We can perform the procedure from the control room, not inside the cath lab, but outside the cath lab, and which is really, really better for the comfort of the operator. How can tomorrow, we can expect tomorrow the use of robotic? Certainly from the lesion characteristic assessment. Thanks to the artificial intelligence, we have a totally different view of the vessel, the lesion, the possibility to have a 3D imaging. Concerning the wiring, it should be certainly totally automated. In other words, the machine, we will print certainly the point at the ostium of the vessel, the lesion, the distality of the vessel, and the wire will follow the line without absolutely no manual performance from the operator on the robotic. Concerning the lesion treatment, it could be balloon, it could be stent, maybe it could be another technology in 10 years. This should be certainly totally automatic. And positioning, of course, of the device to be the same. And we talk about that. Concerning the procedure location, certainly we could perform procedure not in the control room, not in the same hospital, but it could be certainly in another hospital. So what I will say, it's just a dream. We are dreaming. But when you discuss with the people working in the technology of airplane and on this environment, they are ready for this evolution. In other words, here you could see the cockpit of an actual Airbus A320. And today, the pilot is piloting the airplane with, the help of all the computer system. And so we need one or sometimes two co-pilots to pilot this Airbus A320 or the other type of Airbus. I'm not talking about Boeing, only Airbus, because I'm from Toulouse and we have Airbus industry in Toulouse. So the future of the cockpit could be this. In other words, the pilot will have this kind of big screen in front of him, and the takeoff, the landing, all the trip between the two cities will be totally automatic. In other words, the pilot will be in the cockpit just in case of, but everything will be automatic. This is not a dream. This is coming from Thales. They are working on that for the next generation of plane. So what we could believe is that we could have the same evolution. This is the image of the cath lab today. We can perform robotic procedure in the control room. But in the future, we can imagine and dream to work in front of a big screen, exactly like the screen in the airplane in the next 10 years. And the operator should be there just to control in case of. And the machine will perform all the procedure. And again, the operator will be there in case of a complication, something like that. So this will be certainly the future. It's a little bit, we are a little bit dreaming when we are looking at that. But this should be certainly the future in the next 10 years. So this will be based of course, this intelligent surface. The 3D imaging with augmented image will play a major role. There will be a multi-cath lab measurement. And again, everything will be, all this progress will be achieved thanks to the artificial intelligence. Thank you very much.
Jean, for the sake of time, before you wrap up the session, one question. With this perspective for the next 10 years, is the interventional cardiologist a dying animal? Means, is the interventional cardiologist, as he or she is working today, no longer existing in 10 years?
Personally, yes, I'm sure. I'm 71, so in 10 years will be 81.
So you don't take care.
So certainly I will stop my work. No, I think we will need in the future, of course, interventional cardiologists. The problem will be the training. There will be a problem of training. In other words, we will have technically, we could do that, but the problem will be the training. How to train. When we will be a young cardiologist, how to start to train it will be possible in the different, in all the different university hospitals. I'm not sure. Again, when you look at the training of the pilots, there are special centers for training, but it's quite limited. So I could not say that the training center for interventional cardiology will be limited, but certainly we will have some specific large center equipped with this technology, and the people will come from other hospitals to take a sort of fellowship of 6 months, 1 year, in order to practice and train with this new technology.
Okay, thank you. So why don't you wrap up the session?
So we can wrap
briefly
up the session, but we can do without a slide, the slide. So what we could say, it's first, at present time, robotic PCI is effective. It's safe. We saw all this data. And this could be applied or simple or complex lesion like bifurcation, and the most interest is osteal lesion for me. And concerning the devices, we could use today this kind of device, FFR, IVUS, and IVL. The benefit we saw during this session, the benefit for the patient is the precision of the navigation and the precision of stand positioning. And this is, for the patient, a very good point. For the cath lab team, is a full radio protection. We saw the from 80% to close to zero. And the reduction of orthopedic injuries, which is not a small problem. There are more and more today old interventional cardiologists who have some back problem. Interest in robotic in interventional cardiology will be growing with technical improvement. And again, remember this slide comparing the surgery they have at the stage 4, 5, 6, and we are today in PCI at the stage 2. But there will be this kind of improvement. And finally, the future integration of robotic will be accelerated with artificial intelligence and vice versa. And this will be certainly the future of interventional cardiology. Thank you.